medicine clinic, the number 2 patient complaint is problems sleeping at night. The number 1 patient complaint is related to pain. So this is very appropriate to outpatient medicine. And I'm going to talk today about 3 things. One is really insomnia and how you evaluate and manage that. 2 is obstructive sleep apnea. I'm going to talk about home sleep testing, which is just starting to explode. And you may see in the next year a home sleep testing unit in the internal medicine clinic that you'll potentially give to the appropriate patient to be tested at home. And lastly, I'm going to talk about the headache that sleep medicine doctors have in getting people to wear CPAP machines. But I'm going to digress for a few minutes. I don't usually talk about personal things, but it was 30 minutes ago, 50 years ago, to the minute, President Kennedy was assassinated. And of course, none of you were alive, but for me and Dr. Mazur, who was here, was probably maybe the saddest and most memorable moment of our lives. We all remember exactly where we were when we heard the news. I was in a 7th grade class in Camillus, New York, and I remember the teacher coming in or the principal coming in and telling the teacher, and the next 3 days, it was on a Friday, so the whole weekend was spent with the people of the United States and really the world mourning the loss of President Kennedy. He was a 43-year-old man who was elected in 1960. He visited Greenville in 1960 when he was campaigning for president. I actually have a friend in Greenville, Louis Gaylord, who's a prominent attorney, who rode in the car with John Kennedy when he did his speech in Greenville. Jackie was obviously a beautiful young woman. They had 2 young children, which is why this assassination was so very, very sad for all of us. In fact, this was probably a sadder time for me than 9/11. And we all had images that weekend on television of him in the motorcade in Dallas, and they had pictures of Jackie coming up out of this limousine to get help from the Secret Service. President Kennedy is there, and there are more graphic pictures of the bullet going into his brain. And then 2 days later, we had to live through Lee Harvey Oswald was the assassin, and they were moving him from some jail in Dallas, and this guy, Jack Ruby, somehow got in there and then assassinated Lee Harvey Oswald that same weekend. So Oswald was never really tried. The Warren Commission later concluded that he killed President Kennedy, although there's some doubt about that. And then they immediately flew President Kennedy to Washington, D.C. for funeral services, which it was like 24/7 on the television. Very sad. That's Jackie. This is Teddy Kennedy, Senator Edward Kennedy, who died about 5 years ago of a brain tumor. That's Bobby Kennedy, who was the Attorney General. He was assassinated in 1967. And this is an image of this is the caisson that carried President Kennedy with horses and a big parade going up to Arlington Cemetery. Thousands and thousands of people, and of course everybody in America watching it on television. And then, of course, you had these images. This is little John, who died in a plane crash about 10 years ago. Caroline is an attorney and has written a really excellent book on the Bill of Rights. She's probably about 45 years old now. Again, this is Edward Kennedy, a brother, and Bobby, another brother. And then we had images of the caisson going up into the cathedral where they had his funeral. So Thanksgiving, if you're with your parents or grandparents, I'm sure many of them will remember this and they can tell you about the whole weekend. So it's a little digression for me, but it's kind of ironic. This occurred 30 minutes ago, 50 hours to the minute ago, 50 years to the minute, a year, a half hour ago. So it's very memorable and still very sad to those of us who were conscious and, old enough to remember it. Getting back to our sleep talk, we in our modern culture sleep much less than people did 100 years ago. So this is the average sleep time in 2007 of about 9 hours. Now it's on average less than 7 hours. And it has to do with cultural factors. And as you'll see in a few minutes, there's a lot of consequences of inadequate sleep. So in understanding insomnia and difficulty sleeping, I wanted to talk a little bit about the physiology of what makes us sleep and what keeps us awake. We all have a drive to sleep that increases the longer it's been since we've slept. So later this afternoon and into the evening, this drive to sleep will become more and more prominent. And of course, at 10, 11 o'clock tonight, most of us will go to sleep. And sleep deprivation increases that drive. If you've been up for 24 hours, the next night you really go to sleep easily and you sleep a long time. Sleep deprivation causes a decline in cognitive functioning, and that's why we have the 80-hour work week, because a lot of medical errors were occurring because of cognitive impairment from lack of sleep. There's also a circadian rhythm. The suprachiasmatic nucleus in the hypothalamus is a clock, and we all have a little different clock. Some people are night owls, and their clock makes them go to sleep later, say at midnight. Other people, the clock makes them go to sleep earlier. And as we get older, our clock gets earlier and earlier. I go to sleep earlier now than I did 20 years ago. Our daughter, who's in college, the night starts about 11 o'clock, and she goes to sleep maybe at 1 in the morning. So there's this circadian rhythm. We each have a circadian rhythm, and it changes as you get older. A late circadian rhythm, like high school kids have, is really problematic if they have to go to school at 8 o'clock in the morning. They may not really be ready to wake up till 9 or 10 in the morning. And sometimes some teenagers will get on a really late circadian rhythm, and that creates problems. There are neurotransmitters that make us be awake or make us go to sleep. And all of these transmitters promote wakefulness. It's histamine. If you take an antihistamine, some people that will make them sleepy. Hypocretin or orexin is the neurotransmitter involved with narcolepsy. Narcolepsy is like a young person less than age 30 who is sleepy in the daytime. They have sudden sleep attacks, and sometimes they have cataplexy. Cataplexy is like being transiently paralyzed if they're under stress. So they'll say, if I'm laughing or if I'm upset, I kind of fall down. That's cataplexy. So a lot of patients with narcolepsy have cataplexy. And they have a deficiency of orexin. If you measure that in their CSF, it's low, and that's thought to be responsible for their sleepiness, that they lack this kind of stimulating neurotransmitter. There's a the main transmitter that makes us get sleepy as we go on later in the day is adenosine. Many of us in the next hour will drink caffeine, coffee. Coffee blocks adenosine, and so that by blocking a transmitter that makes you sleepy, it makes you awake. So I like to do kind of clinical scenarios. This is a patient that I saw in sleep clinic recently. It was a patient came from family practice for, quote, sleep apnea evaluation, 55-year-old woman whose chief complaint was, I'm sleepy during the daytime. And we see a lot of patients in sleep clinic because of excessive sleepiness. And a lot of people think, well, they ought to have a sleep apnea test. But when we see somebody like that, you should always ask them, when they go to bed, how long it takes to go to sleep. This person woke up at 0100 and took her an hour to go back to sleep, and then she has to get up at 5 in the morning to go to work. So she wakes up tired, sleepy after sleeping only 4 or 5 hours. She did have snoring and obstructed breathing. She was obese, and she was on these medicines. So what would you do in this patient? Would you order a sleep test, an in-lab test, and I'll talk in a few minutes about home sleep testing, discuss sleep hygiene, which I'll get into in a minute, or a trial of Ambien to promote more sleep. So I'll give you a little bit of time and we'll see how people answer this. All right, time is up here. Let's see how we do. So most everybody wants to discuss sleep hygiene, which is the correct answer. So not everybody who's sleepy in the daytime needs a sleep apnea test or a polysomnogram. This patient obviously wasn't sleeping enough at night. She only slept 4 hours. So we want to dig into why that would be. And it may be an issue of caffeine, and I'll talk about sleep hygiene in a minute. In a patient with inadequate sleepiness, you believe, in this patient, you believe that her inadequate sleep and possible sleep apnea were causing the problem. Which of the following is the most likely thing that would cause inadequate sleep? Is it depression, sleep hygiene, restless leg syndrome, medications, or sleep state misperception? Sleep state misperception, some people will tell us they never sleep, but when we put them in a sleep lab and have an EEG on them, they actually are sleeping. And actually all of these things can be a cause of inadequate sleep. But I'm looking for the one that's really the most common. And the answer is poor sleep hygiene. Polling didn't show on this one, but anyhow, the typical story of depression causing problems sleeping is the person can go to sleep relatively easily, but they wake up early. So if somebody says, I go to sleep pretty well at 10 o'clock, but I wake up at 1 a.m., you should maybe dig into more, are they depressed? Restless leg syndrome is really common after the age of 50. About 15 or 20% of people have that. It's the urge to move your legs or rub your legs in the evening hours. And people lay in bed and they kick and rub their legs or get up and walk, and it makes it hard for them to sleep. It's treated with dopamine agonists like ropinirole, and you can really make a patient happy if you put them on that medicine and it corrects the restless leg syndrome. There are many medications, which I'm going to get into in a second, that cause insomnia, and then the sleep state misperception is a little bit unusual. So the definition of insomnia is difficulty falling asleep and or maintaining sleep, non-restorative sleep. And the key is that it goes on for at least a month. All of us have intermittent temporary insomnia. That's not really insomnia. And it causes clinically significant impairment in functioning. I see a lot of elderly people, and they sleep 5 hours at night. And I'll say, Mr. Smith, you know, how do you do in the daytime? We say, oh, fine, I do my gardening and I watch TV or whatever. That person, even though he's only sleeping 5 hours, he really doesn't have insomnia because it's not impairing his functioning. And again, as people get older, they sleep less. So a teenager may sleep 9 hours at night. I sleep about 7 hours at night. Somebody 15 years older than me may only sleep 5 hours at night. So as we get older, we sleep less, and we go to sleep earlier in the daytime. So the medications that can lead to insomnia, I've listed some of them here. Beta blockers is a big one, especially the lipophilic ones like metoprolol that gets in the CNS, clonidine. We've all seen people on prednisone. They come in wired up and they can't sleep. Sudafed, occasionally some SSRIs, obviously caffeine, nicotine. So always kind of look over your patient's medication list, and you may have to look up whether that's one of the medicines that causes insomnia and think about that. Caffeine sometimes will last for over 12 hours, so we tell people no caffeine after about noontime or 1 o'clock. If you drink caffeine at 5 or 6 in the afternoon, for many people, they're not going to sleep at night. So when I see a patient who's sleepy in the daytime, I always think maybe they're sleepy in the daytime because they have sleep apnea. So you ask about snoring or obstructed breathing. And if they have a lot of that, then you do a polysomnogram. Do your legs twitch in the evening? That's restless leg syndrome. Do you sleep well but at the wrong time? So there's circadian rhythm disorders. And that's like the teenager who never goes to sleep before 2 in the morning and then they can't get up till 10 in the morning. That's a difficult thing to change, but in sleep clinic we have therapies that will advance their sleep rhythm. And here's the biggie, sleep hygiene. So ask people about regular time for going to bed. Do they watch television in bed? And I've got a slide more on sleep hygiene. What other diseases do you have? Patients with COPD and pain have trouble sleeping. And if I see somebody who doesn't sleep because of pain, I say, you have to go back to the pain clinic and get that pain taken care of, or you won't sleep. So cognitive behavior therapy is probably the most common thing we do to treat insomnia. There's a thing called stimulus control, which basically means in the bedroom, it's just for sleep. You don't be watching TV or doing the computer or reading in bed. You tell people to go out to another room, watch TV, read. When you get sleepy, then go into the bedroom and go to sleep. And likewise, if you wake up and you're tossing and turning and not going back to sleep, don't just stay in bed. Go to another room, read or watch TV, and then go back to sleep. Sleep restriction is, a lot of people think, well, it's 10 o'clock at night, I ought to go to bed. But they're not sleepy. And then they just toss and turn. Tell them not to go to bed until they're sleepy. So do something in another room. And don't do vigorous exercise in the evening. That will cause people to stay awake. So there's a lot of consequences of inadequate sleep. There's a higher incidence of diabetes, obesity, cardiovascular disease, psychological stress, cognitive impairment. And in a minute, when I talk about consequences of untreated sleep apnea, you're going to see this same list. So people who have untreated sleep apnea frequently do not get good, adequate sleep at night because they have arousals all night. So underneath the thing at the top is, if you've been up all night, let's suppose you were on call last night, you've been up for 24 hours, the next morning, which one of these applies to you? You want donuts, you're not hungry, you eat fruits and vegetables, you want meat. See if you guys follow the pattern of what the science says should be the right answer here. I'll give you another couple seconds. Listen. Yeah, donuts. So there's a reason for why people want high-fat food if they're sleep deprived. And this has a partial explanation for why people who don't sleep have a higher tendency to be obese. There must be some health nuts in here who eat fruits and vegetables in the next morning. And not just hungry, tired 30%, but most of us get pretty hungry. Question?
I was just wondering when is the data on the, like, around the day, is it this usually in the diet?
Right. This was the exact study where this comes from, it's been a while since I've read it, so I can't honestly tell you exactly where it came from, but there's an explanation for it. So leptin is made in your liver. Leptin's a nice hormone that reduces your appetite. But if you don't eat, you have less leptin, so therefore you have increased appetite. Also, if you are sleep deprived, your stomach makes more ghrelin. Ghrelin increases your appetite and makes you want to eat high-fat foods and salty foods. So if you're sleep deprived, you're going to have less leptin, and that makes you have more appetite. You'll have more ghrelin that also makes you have greater appetite. So there's some scientific basis for this. It's interesting, the bariatric surgery population of people who are really obese, they actually have high leptin levels, but receptors in their brain become insensitive to the leptin. So even though they have a lot of leptin, which you would think would make them not eat, their brain receptors aren't working, and so they're always hungry, even though they have plenty of leptin. And I think pharmaceutical companies are really working on a way to improve leptin sensitivity in bariatric patients, because if you could do that, they wouldn't be eating all the time. I'm going to shift gears now and talk about sleep apnea, and talk about who should be referred for testing, who should have a home sleep test, treatment options of CPAP, dental procedures, the risks of untreated sleep apnea. So when you're thinking about who to refer for a sleep test, a lot of times we'll do this stop-bang questionnaire. And if 3 or more of these are positive, that's a high likelihood that they have sleep apnea. So people tell you they're snoring. T is for tired, which is really sleepy. O is for the spouse or friend says they have observed obstructions. They have hypertension, high BMI, older age, thick neck, males. All of these are risk factors for obstructive sleep apnea. You're going to walk out of here and not remember this stop-bang thing, but a simple thing to remember is, do you snore, and do you have a thick neck, and do people say you have obstructed breathing? they answer positively to those three things, they probably need a sleep test. So we have a 55-year-old man who snores and he wakes up tired. He has morning headaches, which is a common symptom of sleep apnea. He has a thick neck. Wife has observed obstructed breathing. He has no other diseases other than high blood pressure. He says he sleeps well at night. Which of these three tests would be done? And I'll kind of help you answer the question in a minute, but and we're going to talk about who should have a home sleep test and who needs an in-lab test. A lot of you are slow on the trigger. Let's see how you do. So in-lab polysomnogram, 72%, 28% is a home sleep test. Split night polysomnogram was 0. The correct answer here in this relatively uncomplicated patient, he doesn't have heart failure and COPD, he doesn't have insomnia or psychological disease. This patient is an ideal candidate for a home sleep test. And at the Vidin Sleep Lab and the ECU Sleep Lab, just in the last couple months, we have this new watermark system. And I actually did a test on myself. It's just this headband that has a thermistor that measures airflow here. It measures 2 channels of EEG. It has an oximeter on it that's measuring your O2 sat from the skin in your forehead. So it tells me O2 sat, it tells me airflow, it gives me an idea of whether the patient's asleep. And it's really a reliable test to give you an apnea-hypopnea index. Apnea-hypopnea index is the number of apneas and hypopneas per hour sleep. And so home sleep testing costs, or the insurance companies pay about $300 for this test. If you do an in-lab test, it's about $1,200. You can imagine that the payers really are putting pressure on us to do home sleep tests. And for many people, it's a very good test. The state of Massachusetts, you cannot get an in-lab test, or the providers won't pay for it unless you have only very certain conditions. And this is kind of exploding across America. Right now at the Vidin Sleep Lab, 40% of the sleep tests we're doing are home sleep tests. A split night polysomnogram is when a patient is in the lab. The first 2 hours of the test show severe sleep apnea. The technician will then put a CPAP machine on the patient and titrate him for the rest of the night. That way the patient can get by with just one sleep test and have a proper CPAP. With an in-lab test, patient comes in at 8 o'clock, sleeps all night. We look at the result if they have moderate or severe sleep apnea. Then they have to come back for a second night, wear the CPAP, and get the pressure set right. So traditionally, people with sleep apnea had 2 of these tests at about $1,200 a pop. And now, with this model, patient, if they have moderate or severe sleep apnea on this test, they then have to have an in-lab CPAP titration. But obviously, saves a lot of money. And a lot of patients out there say, I don't want to go in one of those sleep labs and sleep with all that mess on, but they will sleep at home with this little thing on their head. So the American Society of Sleep Medicine guidelines for home sleep testing, a sleep physician should see the patient at some time to make sure the treatment's being done. So some local doc-in-the-box shop doing this is really not doing good medicine. It can be an alternative to an in-lab test in patients who have a high pretest probability for moderate or severe sleep apnea. So patients who have 3 of those stop-bang questions positive. You know, they got a thick neck, they're snoring, they're sleepy, would be a candidate for it. However, you would not do a home sleep test in somebody who has insomnia, narcolepsy, stage 3 or 4 heart failure, class 3 or 4 heart failure, severe COPD, or cognitive impairment. So if somebody has insomnia, the home sleep test isn't really going to give us the answer because they may not have enough sleep. If they have severe congestive heart failure, a lot of those patients have central sleep apnea, Cheyne-Stokes breathing, and the home sleep test is not very accurate for that. Demented patients, nursing home patients, they're not going to do this thing properly, and it's not going to be a good test. So these are the people who you would not do a home sleep test on, and it's not a screening tool. So it's, you know, like the patient I presented earlier, relatively healthy guy with hypertension, not a lot of comorbidities, doesn't have insomnia, and he has a high probability of sleep apnea. Uh-huh. For a home sleep test, they pay $300, and unfortunately, the 3 Mercedes that I used to own are going to be downsized to Chevrolets because the Blue Cross is going to pay $300 to, say, ECU Sleep Lab for this home sleep test. ECU Sleep Lab then puts $300 toward my compensation, or puts $30. That's what I get for interpreting a home sleep test. Now, you can do it in about 10 or 15 minutes, whereas the old in-lab test is $1,200, plus the doctor charges another $160 for interpreting it. So that it's a big change in finances, and in a way it's reasonable and justified. And does that answer that? Okay. Blue Cross of Virginia now says no in-lab tests unless you have, you know, one of these things. Blue Cross of North Carolina hasn't come down that hard, so we still do some in-lab tests, but really many of our in-lab tests could be done home, sleep tests. So a new paradigm for sleep testing. We're in the near future going to put a watermark system in Vidant Cardiology office because so many people with atrial fibrillation and bad hypertension and heart disease, they don't have bad heart failure, they really need to be tested for sleep apnea. So the nurse practitioner at Vidant Cardiology or ECU Cardiology, they'll talk to the patient, high likelihood of sleep apnea, not a lot of other problems. They'll give the home sleep test unit right then and there to the patient. He'll take it home, return it the next day. Electronically, it comes to my computer. I'll interpret it. And so you get, within 3 days, you have a diagnosis of sleep apnea, and then you can arrange for a CPAP titration. We're also going to go to the medicine clinic at Beaufort County Hospital, Beaufort Vidant, and those doctors have expressed an interest in it. You know, maybe a year from now, an ECU internal medicine clinic, you'll have this system, and as long as you pick the right patients, it'll facilitate testing patients for sleep apnea, whereas now the complaint is, oh, I got to call and schedule an appointment. That takes a month, and then it takes 3 more weeks to get an in-lab polysomnogram, and then a CPAP, and you know, by then the patient gets exhausted and his bank account is depleted. So this will really facilitate testing of a lot of patients who have sleep apnea who have never been tested. But at some point after this testing is done, they will see the sleep physician to say, you know, you really should be on this CPAP. sleep physicians really do a much better job of getting patients to wear CPAP. We know certain educational points, certain tricks to do. And a lot of primary care docs don't like to get involved with CPAP machines and all this stuff. So the sleep physician will still be involved with it. Many severe consequences of untreated sleep apnea. They have fragmented sleep, higher risk of diabetes. You all know that if somebody has hypertension and it takes 3 or more agents to control the hypertension, you should seriously consider sleep apnea as a cause of it. Causes increased inflammation in the body. CRP levels are elevated, and that translates into coronary artery disease. So the cardiac implications of untreated sleep apnea are, as you know, atrial fibrillation. If a cardiologist converts somebody with atrial fibrillation, they really should also consider, does this person have sleep apnea? Because if they don't treat the sleep apnea, the AFib will recur. Coronary artery disease incidence is much higher in untreated sleep apnea patients. Sudden cardiac death is, there was a football player from the Carolina Panthers a few years ago who died suddenly, and you can imagine most of these 300-pound linemen probably have sleep apnea. LV systolic and diastolic function is very common. And again, hypertension. And the mechanism for all of this is really when you intermittently stop breathing at night, your O2 sat falls, your carotid bodies send a signal to your brain to cause sympathetic stimulation. So there's a lot of catecholamines being produced, sympathetic stimulation, and that leads to the hypertension, stroke, heart failure, atrial fibrillation, and the mechanism again is the sympathetic activation. You have, it's a pro-inflammatory state, oxidative stress, endothelial dysfunction. Endothelial cells are less responsive to nitric oxide. The hypertension causes LV afterload. Sympathetic stimulation leads to diastolic dysfunction. And then, as we talked about earlier, people who don't sleep well eat more, they get obese, insulin resistant, so it's really a perfect storm. And when I'm talking to patients about wearing their CPAP, you know, a lot of people think, oh, it's just something I do to make my wife happy. But you educate them about all this, and you'll have a much higher success of getting them to wear the CPAP. So who should be put on CPAP therapy? People with moderate to severe sleep apnea, and that's 15 to 30 AHI is moderate, severe is greater than 30. A lot of the mild sleep apnea patients, if their apnea-hypopnea index is only 10, a lot of them I don't treat. I tell them to come back and lose weight. But if they have comorbidities like hypertension, cardiac disease, maybe they've had an MI, diabetes, then we definitely recommend they get treated. Or if they're mild but they have sleepiness and morning headaches, they're symptomatic. The way that CPAP works, in untreated sleep apnea, the obstruction is really back down in the hypopharynx. The tongue is enlarged, airway is narrowed, and when the person sleeps, it all relaxes much more than it should, and so it collapses. And if the person drinks alcohol, that further relaxes these muscles. And CPAP, by blowing air through here, the positive pressure splints the airway open. 10 years ago, some patients used to get the UPP, the surgery that removed the uvula. Really didn't work because if you move the uvula, you still have an obstruction further down. So most people who had the UPP were sorry they had it done because it was painful. It temporarily made their snoring better, but a year later their sleep apnea is still present. So if you have a patient who had severe sleep apnea, and he's not wearing CPAP, and you probably have seen patients in the clinic, severe sleep apnea, they say, no, I'm not wearing that CPAP machine. What can you do to improve compliance? And some of you probably know Medicare and insurance companies insist that compliance be documented within 90 days of the sleep study. All these CPAP machines have a chip in it. We put it in our computer, and it tells us the number of hours the person is wearing it and how many nights per week. Definition of compliance is greater than 4 hours per night, at least 60% of nights. So it's a pretty loose definition of compliance. But if that's not documented, Medicare and insurance companies take the CPAP machine back. So the best answer here is A. Again, educating the patients about the consequences of untreated sleep apnea. Sometimes we tell them to go back to the DME company and try a new mask. AutoPAP is a titration they can do that adjusts the pressure up and down all night, and some patients like that better and will improve their compliance. But the best thing is really education of the patient. Uh-huh. Unfortunately, and this is the thing we really stress with patients, if they have taken the machine away because of non-compliance, and it's been, like, let's say this was a year or two ago that they took the machine away, they have to go all through sleep testing again. So they have to have a whole new sleep test and reprove sleep apnea and a new CPAP titration. They'll pay, 80% of it. But if you're having an in-lab test, 80% of $1,200, they're still going to have some out-of-pocket. So we really say, you got to wear this 4 hours a night, 60% of the nights, or they're going to take it away. Yeah. A lot of people have claustrophobia, and I always ask them if they have claustrophobia. There's nasal pillows that are real small. They'll go in there. Basically, everybody's different. So there's about 5 different masks, and they go to the DME provider, and they try different ones and pick out the one that they think they'll like the best. So definitely changing mask helps compliance. So here's a patient who had mild sleep apnea. He was sleepy, prior MI, and he can't wear the CPAP machine. You've tried masks, you've educated him, and sometimes early on with CPAP treatment, we'll give him Ambien for a week to get him to sleep, get used to it, and that'll improve compliance. But there are some people who just, for whatever reason, you've done everything, they can't wear CPAP. And this patient had a prior MI, so he's got coronary disease, so you'd really like him to be treated. These are the options you have. You could send him to an ENT surgeon, dentist for oral appliance, lose weight and come back in a year, or just treat him with nasal oxygen to treat the hypoxemia. So we get it all over the map. Number 2 is the best answer here. This is a place for the oral appliance that it's like a mouth guard. It pulls the mandible forward slightly. Our dental school has people interested in doing that. I've sent some patients over there for that. In my experience, some patients, after a year or so, they don't like the feeling of their jaw and they stop wearing it. You can occasionally get temporal mandibular joint problems, You can't use an oral appliance if they have really bad dentition or no teeth. You could consider telling them to lose weight and come back in a year, but we all know that success of losing weight's not very good. And he has coronary disease, so I'd really like to treat him. Nasal oxygen will correct the hypoxemia, but the patient will still be having obstructive apneas at night. And part of the sympathetic stimulation comes from these obstructive apneas and arousals and not getting good sleep. So the oxygen probably helps them some, but really doesn't reduce some of this sympathetic stimulation. And at least in Greenville, surgery for sleep apnea, other than in a teenager with huge tonsils, is really not done. So the pediatricians do send them for tonsillectomy, and that's very effective, but that's pretty much only in teenagers. And this is an example of a device that pulls the mandible forward. Okay. And so that's pretty much it. This was the last question. It was about a patient who's wearing CPAP and they're still sleepy in the daytime. That is an indication for stimulant therapy like Provigil or Nuvigil. Thank you very much. We have Dr. Bowling with lung cancer to follow.